The subcommittee will come
Privacy
to order.
concerns are also intimately related. That's why I'm concerned about the changes to our health privacy law that this bill proposes. It creates entire new standards for individuals who have what the bill loosely defines as serious mental illness, and that's a loose definition, unfortunately. And I know these are difficult areas to find the right path, but that's something we really need to get to. Dr. Schern, first, can you help us clear up a key point of fact? As HIPAA always require patients to give their permission before information is shared, or do providers have flexibility if there is a threat or if they believe the patient lacks capacity?
It's my understanding that there is flexibility. And, I was thinking also about the Virginia Tech shooting, and when people looked at FERPA and HIPAA then, it was clear that there was a lot of misunderstanding about the bill, and that in emergency situations
Yes.
that can be violent. So part of the thing I think we need, and I think Ms. Thompson would agree, is just better public education about what those laws
Absolutely.
actually mean.
I'm glad you put that on the record. What impact will the changes proposed in the bill have on people's willingness? Is that a concern to you, people's willingness to seek treatment for mental health illness?
It is a concern of mine, concern of our organization, given the coercive nature of some of the assisted the outpatient treatment programs.
Thank you. I yield back.
Chair,
I want
thanks,
to point out
gentlelady.
there's misunderstandings of the HIPAA law, and Dr. Stern, you've never been involved in a case, and you shouldn't be able to have an opinion on it. This bill does not undo HIPAA laws. It clarifies them, and we want to work on language. I've been talking with Representative Daggett on this too. We want to make it so that all those things that are also in the regulations that go along with the law are clarified. It doesn't change anything, but there are a lot of misunderstandings. You're absolutely right. Clinicians misunderstand this all the time. So we want to make sure we work on clarify that, but it doesn't change the law. Thank you.
Now recognize the gentleman from Louisiana, Dr. Cassidy. 5 minutes for questions.
I think the gentleman, Dr. Shern, you already mentioned you didn't read the bill. So is there a specific place in this bill that you can make reference to where you have these concerns about the Secretary of Mental Health and what that person will do to limit care? Is there some specific page or paragraph you can reference to clarify your conclusions?
I'm sorry, Dr. Murphy, I'm not understanding the question.
Well, you made a statement to the gentlelady that this person who would be the Secretary of Mental Health would over-bureaucratize and complicate some of these issues. Is there a specific place in the bill you can tell me where it says that?
What I was responding
I need
to,
a specific. I don't need concepts or philosophy. Because what we're trying to do with this hearing is work to improve the bill. So if you think there's something in there, it's important this committee has accurate information and not impressions. Is there something in the bill that, if you don't, you can get back to me on that. That's okay.
the question I was responding to had to do with conditioning the receipt of block grant funds based upon states having effective assisted outpatient treatment
And I think
provisions. And it's my understanding, and correct me if I'm wrong, that is in fact a provision of the bill.
It is.
I would oppose
that is a provision of the bill. That's not the issue with the Secretary of Mental Health. Secretary of Mental Health.
No, that wasn't the question, though.
Well, part of it. You said it would over bureaucratize. Do you what is the person who now heads SAMHSA? Do you know what her degree is in? What her background is?
She's an attorney.
Exactly. Haven't we done enough with treating people with mental illness as legal cases? We have closed our hospitals and filled our prisons. We have closed our treatment centers. We have not given adequate funding to community mental health centers, and we've replaced the hospital bed with a flop house or a blanket over some steam grate. That's wrong. I think it's immoral. It puts us in a third world category.
I agree with you completely. I think
I want, for the record, I want the committee to know.
Though.
Yes. There's a lot to do. A person's background should meet their role. Now, I respect that you're here, but it's important to understand you don't treat patients. You have never been involved in a patient case. You have never been involved in HIPAA discussion. You haven't. You haven't, and that's important. You are here as a citizen. But I want to make it very...
Here's a research psychologist who studied these issues for
I understand,
many
sir,
years.
but you haven't read the bill, okay? Sir, along these lines, let me clarify for the committee. It's my time. Let me clarify for the committee. The federal government spends $125 billion a year across many agencies. The Department of Defense has spent $100 million, and a group just said that the money they spend on resilience programs and other things doesn't work. DOD has to go back and say, what did we do wrong? Well, we found out that some of the things they're doing is in clearly good programs with regard to evidence-based programs, and some of it is not, and they need to make sure people are following the program. The VA spends a lot of money in mental health, but unfortunately, a study said that about 20% of the time when someone goes into a VA hospital for mental health services for PTSD, they get appropriate care. The rest of the time, they don't. That's wrong. Judiciary spends a heck of a lot of money, and in many states, on jails. That's wrong. We should be treating these people and not letting them go to that area. And we've had many witnesses before this community that does that. The purpose of the Secretary of Mental Health, and I think you're demeaning the quality of this. I don't want someone who is dealing with 60 million Americans, that 1 out of 5 or 1 out of 4 people will deal with in life, to be some backbench, low-level person. I want this person to have some power and mojo. I want this person to be a clinician of an MD, PhD, or DO level. I want this person to be one who has the access behind their title, Assistant Secretary of Mental Health, to be able to walk into the offices of Judiciary, Defense, VA, Education, HHS, and say, we want your information. We need to know if your programs work or don't work, or if they're redundant. We've got to make this system work. Sir, for the last 20 years that SAMHSA has been around, it's gotten worse. Now, SAMHSA has done a lot of great things, and I applaud them for that, and we want to keep them going. I'm not interested in getting rid of them. I'm interested in beefing them up. But I'm also interested in saying we need evidence-based programs around this country. There's a lot of misinformation being thrown around today, so I'm frustrated. But I also know, you know what, that's the nature of the mental health community. For the first time since Kennedy was president, for the first time in the last 50 years, we have an opportunity in this Congress to say we need to overhaul this system. There have been some great programs that have come through. I applaud Congressman Kennedy and Senator Wellstone. Some of those things have been marvelous, but it's been piecemeal. And I want us to really approach this in a comprehensive way, but sometimes in the mental health community, we're so used to dealing with the dysfunction in ourselves, we don't understand when we have an opportunity. So here's what I'm recommending. When you're given a comment and you haven't read the bill, say, I haven't read the bill, okay? And with regard to this, what we want, what I want, is from everybody, and all the agencies who are out there spreading rumors about this bill too, to my colleagues and other people, send me ideas for amendments. Let's work on this. But let's not play this game. Thank you. I yield back. Thank the gentleman for yielding. A couple of the clarifying points I want to make for members. This bill does not cut 85% of federal funding for these programs. It does not. There are multiple sources for that federal funding. This is one of them. And so it's very important that people are dealing with the facts there too. Dr. you referred to a coercive feature of assisted outpatient treatment and would make people seek treatment. Are you aware of the programs Ms. Zanowitz is talking about here with regard to the evidence on when AOT can work to reduce incarceration, et cetera?
Yes, I am.
So what I'm trying to find out here, and I recognize not all states do things the same way. For
Right.
example, California has one county that
Right.
does this, the rest don't. And some states do it better than others. I think New York does a pretty good job on that. But in this bill, are you aware of how we define who would qualify for assisted outpatient treatment?
Generally, yes.
Well, we very narrowly define that. They've had to be incarcerated before, had multiple hospitalizations. But the rest we leave up to the states, because I think states should decide a lot of this too. So I want to make sure we're making it clear. There's no coercion involved here, but we're saying states have to have something on the books. But let me ask what we're saying here is that it's an alternative to just waiting until someone is in imminent danger, until someone has a knife to their head or someone else's. We want to provide a mechanism by which people are not just waiting for that someone's about to die standard. That's something established in the 1700s. We need to be doing more. So what I want to ask here is, I'm open to other ideas, and what else can we do to make sure we have this integrated care, this wraparound care? I mean, we know when someone is in an acute crisis that they need a lot of help and long term. What would be a couple of those things? Ms. Thompson, can you think of anything that we should make sure we include here?
Well, I think the HIPAA, how HIPAA is dressed is vital because, you know, waiting until somebody is at a risk to themselves and others is waiting way too long to help them. We're waiting way too long to step in.
So making sure we have some ways that families can participate more would be helpful.
That's
Dr. Stern,
right.
do you have any recommendations of ways we could help provide some of those integrated wraparound services? I mean, we have some in here now under the Excellence in Healthcare. You don't have to answer now, but if you can provide us some ideas, I'd love to hear.
No, and I think we have a pretty good evidence base with regard to that. And I think that
Good.
where AOT has been shown to be successful is in New York, where there was a $125 million appropriation to enhance services.
And off the record, they saved a heck of a lot of money on jails, didn't they?
Yeah.
We have to
I
we
think,
have to
believe
convince
me,
other states.
Enhancing services, I think, is a very smart idea. You know, we agree on 99% of these issues.
Okay. Ms. Zanowitz, I'll get back to you, Ms. Zanowitz. Do you have any other suggestions we can do? I know you're in support of AOT, but any other things states should be doing, we can help them?
Well, I mentioned earlier, I just finished a survey of jails and prisons around the country. And this is where we need more help. And it's something that's being overlooked. I think it's coming to the forefront now, but that's where there are so many people with mental illnesses who are refusing treatment. And what happens to them in those situations? I have talked to jails and learned just how horrible and dangerous and heartbreaking it is. And I think it's something that we have to focus on. And not only just providing treatment in the institutions, but keeping them out of the institutions. And I've talked to police officers trained to deal with people with mental illness. I was in a meeting where they asked, after hearing all the evidence, you know, the recovery-based peer support programs the state provides, a police officer stood up and said, well, when I call the state, I can't get any help for this homeless person who is psychotic and delusional. So I think those are the areas that we need to have more integrated services.
Mr. Chairman, for the record, I just want to point out that it's in support of what Dr. Stern is saying. A report says that ACT works, but a report says we also found evidence in the case manager data that receiving AOT combined with ACT services, assertive community treatment, substantially lowers risk of hospitalization compared to receiving ACT alone. So we'll work with you on that. Thank you. And I also thank you for your commitment to help us improve that language. It's important. We've had too many people raise concerns. We have to do it the right way. Dr. Stern, you had mentioned that you're aware, let me ask you, are you aware of any study at all, empirical published study, support your understanding that broader commitment standards drive people away from seeking treatment? Are you aware of any particular study offhand, or can you provide that for us?
I can look into it. I'm not aware of any offhand.
Okay, I appreciate that, because you made this statement. I want it backed up with evidence. I also want to say that what I was reading before, the quote I forgot to reference, is where it said that AOT combined with ACT services substantially lowers risk of hospitalization compared to receiving ACT alone. This is in the study done by Duke University Policy Research Associates and the University of Virginia School of Law on the New York State Assisted Outpatient Treatment Program evaluation. So a lot we can learn from New York. One other thing I want to mention, when I refer to some of the concerns I have, and Ms. Jensen, you brought a very compelling story forward on what happened with that horrible place you were in, and I'm glad you fought hard to shut it down. Also, some of these groups also caused some problems too. A case we heard was from Joe Bruce. His son, William, was diagnosed with some psychosis, who was in Maine, and these advocates came in. This family was completely cut off from being able to talk to their son, which is a HIPAA issue. Yet these advocates could talk to him, coached him during a hearing on this, and told him to say, when he was asked if he was going to be a harm to himself or someone else, say no. He listened to their coaching. He was dismissed from the hospital. He went home. He took a hatchet and chopped his mother to pieces. This was very moving testimony this committee heard. We don't think a group like this has any business telling someone, get them out of treatment altogether. We want professionals involved who are looking out for the best interest of the patients all the way through. Mr. Chairman, I want to thank you for this hearing today. We've heard some powerful information. I look forward to working with my colleagues on both sides of the aisle on this. The good news is we have elevated this to the level of congressional discussion instead of keeping it in the dark shadows. We have understood that this isn't just an issue of violently mentally ill. This is severely mentally ill. We have to work together. I'm excited about this, and I want to leave with a message of hope for the many people who are struggling with mental illness. We will continue to listen to you. We want to work together. We have got to change this system and help you all. And with that, I yield back.